Good evening and welcome to this much needed discussion tonight. We are at this point blank. We are still in the middle of this pandemic, and I know it feels like we're getting close to 2022, and we're like, this should be done by now. That was 2020. It's almost 2022. I'm ready to get back to my life. I'm ready to go back to the movie theaters. I haven't been back to the movie theater. I forgot about the movie theaters, but
me neither.
We just, we want to get back to life so bad. And so, but then recently we've had a new variant pop up and it spread very, very quickly. It was like 1 week it was in South Africa. And then a week or two later, it was in 38 states here in the United States, and it might be in all 50 by now. So we decided to come here tonight to kind of give you all an update of where we are with regards to vaccines, variants, what you need to know, what you should know, and just kind of give people an update. We're going to talk about boosters. We're going to talk about vaccinated kids tonight. We're going to talk about vaccine mandates, because I know that's a hot topic, vaccine mandates. We're going to talk about travel restrictions. I know some people want to get out and start traveling, and I understand. I traveled recently, and it is difficult, but it can be done. It can be done, but you have to do it in a safe way. And you have to check a lot. There's a lot of rules for each country has a different rule. Each states have now are enforcing rules. So we just got to be more careful. So we're going to have to tease through all this. So we got a wonderful panel tonight to talk about all that. And as you can see, I am not alone tonight. I have got my good friend, Dr. Mrna. Dr. Mrna, how are you doing?
I am great and excited for this discussion.
Absolutely, absolutely. So when you said, hey, we're going to do this vaccine and various updates here, what were your first thoughts?
I was like, when is this going to be over? But but no, my first thought is it's almost Christmas, and Thanksgiving, I think, has hammered us, which is why we are seeing what's going on now. Here in the state of Michigan, the numbers now are higher than they were last year this time. So this is awful. That's awful. And I mean, literally, every day we are seeing the numbers. I mean, 4 and 5 feet, like just climbing. So it's just, and then Michigan actually they've been on all of the national news too, because the numbers have been so bad. We've heard about our major hospital systems shut down. One hospital system called in the National Guard already because they just don't have the staff to handle it.
Right. So, even though we made all this progress and we've had all these wonderful things happen, it seems like we're closer to square one. It feels like we take 2 steps forward and 1 back, which is a challenge when we're trying to get past all this and get back to some sense of normality. So we've got a wonderful panel. So we're going to go ahead and get started because we got a lot to do in a short amount of time to do it. So our first panelist up tonight is Dr. Keith Crawford. Y'all, he is not a stranger to Black Doctor. Dr. Crawford. Yeah, there we go. He's not a stranger to Black Doctor. He has been a contributor. He's written articles, and he has been a regular on these type of programs. He works at the NIH, so he understands how vaccines are developed. He understands research, and so we brought him on here to kind of set the foundation for where we are. So, Dr. Crawford, welcome. Thank you for joining us.
Thank you. Thanks for inviting me. Can you hear me okay?
Yes,
yep.
Yes, we hear you great.
Thanks.
So first question for you, Dr. Crawford, is this. What is mRNA technology and what impact does it have on the body?
Okay. So first, let's just kind of think of how vaccines have traditionally been produced. And there are many different ways to manufacture a vaccine. The goal for the vaccine is that your body, your immune system, needs to be able to see the organism that it is going to fight against. So we're kind of giving the immune system a sneak peek of whatever the virus or bacteria is that we want to fight. Now, we used to take the whole organism. We would either weaken the virus, weaken the bacteria, or kill it and use that to make the vaccine, which means your immune system would actually get to see the whole thing. Then we said, well, maybe we can take bits or pieces of the organism, pieces of the virus or pieces of the bacteria, pieces of the protein, So we could make a vaccine with protein, certain viral proteins or bacterial proteins. We could use that to make the vaccine. So now we're kind of getting a little lazy. We're like, you know what? Let's let our body do the work. Let's let our body make the proteins and stuff. So what a messenger RNA vaccine is, it's the messenger RNA. That is the genetic code. That is what your body is going to use to make the proteins with. That's how we make our own proteins. We produce messenger RNA. It has the code to make whatever protein it is we're trying to make. So viruses work the same way. So this is the message. This is the message for what we call the spike protein. And we'll talk more about this because it's really important. But this is the message, the code for the spike protein. That is what your immune system sees to fight off the coronavirus. So when you get the vaccine, it's able to enter into your cells, and your body is able to read that messenger RNA and make the spike protein. The good thing is when you talk about the effects that it has on the body, your body doesn't like to have messenger RNA lingering around. So after it makes the protein, it's eliminated. Your body, your cells get rid of the mess. So you don't have the messenger RNA lingering around. The other thing that's important to understand, because people were saying, oh, this is going to get into your DNA or it's going to get into your genes and screw things up. Well, if you remember from biology, RNA is not DNA. This does not get into your DNA. It does not get into your genes. When you get your vaccine, it goes into the cells. Your cells make the protein. Your immune system responds. And that's it. And that's it.
I think that's important for people to really recognize and understand. It does not stay in the body. So we're going to just summarize that. It does not stay in the body. Teaches your body how to make the protein, how to make some antibodies, and then then it leaves. And then so now your body, okay, you got it's like a study sheet, right? You got the study guide for if you ever had to take the test, which is COVID. So that's just the simple thing for messenger RNA. So that's two of the vaccines that we have available. So that is Pfizer and Mrna. Right. How is the Johnson & Johnson vaccine constructed? Because I know it's not an mRNA. So we want to get people a full understanding.
Right. So the Johnson & Johnson, which is also the same approach that the AstraZeneca uses, is slightly different, but it's kind of the similar approach. In other words, they're going to get your body to make the spike protein or to make the protein, but it's doing it a little differently. Now, this is going to sound a little bit scary because it's actually using a modified virus to transfer the genetic material. Okay. So this is what we call an adenovirus. These are viruses that are not dangerous, and this virus is modified so it can't harm you, it can't infect you, it can't cause any disease. All it does is deliver the genetic code for the spike protein the same way as the messenger RNA does. So this is just a different way. We're just using the virus to deliver the genetic material. And then your body's going to make the protein. Your immune system is going to see it and produce antibodies. And the important thing is, once your immune system learns how to produce antibodies, the cells that make that antibody stick around for a very, very long time. And so those cells can be mobilized later on. If you need them to make more antibody, they're available to do that. That's one of the ways that the immune system can remember how to make those antibodies, and other ways that the immune system fights the infection.
Okay, so we've heard this word. I thought it was one of the new fraternities that are coming out, Omicron. So we've heard Omicron. What is Omicron, and how is it different from Beta and Delta, Alpha, Beta, and Delta?
Right. So Omicron, and again, everything that I say about Omicron, we have to put it in context. Okay. That we've only been studying this new variant for like 3 weeks. Every time one of these variants pop up, we have 50 million questions, which are valid questions.
Right.
But we don't always have the answer. So what we say or what we think now could always change. But Omicron is the latest variant. It was first identified in South Africa. Now, I always say it was first identified because many of these variants, we call it the British variant or the Brazilian variant or the Indian variant. Many of these variants could pop up anywhere. Right. So they're responding to how the virus basically evolves. They could pop up anywhere, but they were first identified in this particular country. And so that's why it's probably good to call it Omicron or use one of the Greek alphabet. And I know you know your Greek alphabet, Mr. Dean, and we're getting pretty close to Omega, so that's a little scary. But right. So Omicron is really peculiar. Okay. Because it has a lot of mutations. And so it has mutations in this part of the virus we call the spike protein that I just mentioned. Mm. So if you think of a coronavirus, I like to use the analogy, it looks like a soccer ball with spikes. Mm. So think of a soccer ball, or maybe in honor of Steph Curry, we'll think of a basketball. Say whatever your preferred ball is, think of a ball with spikes. And those spikes are important to the virus. The spike protein is what the virus uses to latch onto our cells and infect our cells. That's how it gets into our body and our cells, using that spike protein. But that spike protein is also what the immune system sees to develop antibodies and launch an attack against it. So the virus is trying to change that by making mutations for two main reasons. One, can I change it so I can infect easier? Can I become more contagious? Can I spread easier? So if I change the structure, if I have a mutation that changes the structure of my spike protein, can I get into cells easier? Can I spread easier? Right. Also, can I escape the immune system? Because if you got antibodies that are used to recognizing the spike protein, well, guess what? I've just changed my spike protein. Right. So maybe those antibodies don't work as well. Maybe if you got vaccinated, those antibodies don't work as well. So Omicron is a variant that has a lot of mutation. It has more than any of the other variants. You may ask, how does it differ from Delta? It differs from Delta. It has most of the same mutations that Delta has, but it has a lot more. How does it compare to Delta in terms of transmissibility, in terms of contagiousness, in terms of how well it's spread? It seems to be spread easier. And that is scary because Delta is spread really easy. So why would you have a mutation? Because it gives you an advantage. So if Delta spreads easy, this mutation spreads easier. And one of the ways we know that is from what we've observed in South Africa. Delta used to be the predominant variant in South Africa. Literally within these few weeks, the majority, when I say the majority, more than 90% of the variants being identified in South Africa at this point are Omicron. So it has rapidly taken over. And so that gives us an idea that it is spread more rapidly. I'm going to talk a little bit more about this later. So it's spread more rapidly. Well, next question, is it more dangerous? Is it more deadly? Delta was a more deadly virus than some of the earlier variants. Omicron doesn't seem to be, as it's spread more easily, but it doesn't seem to be as deadly. And if you look at data that we got from South Africa, again, that's the best comparison we have because that's where the most cases are. What we call the D614G variant. That is the variant that caused most of the infections last year. This variant seems to be milder. It seems to cause 30% fewer hospitalizations and cases of severe disease. So it's milder than the variant from last year, which Delta is more aggressive than that variant. So this should be, or we think, is a less aggressive variant than Delta is.
Okay, so just for those of us that sat in the back of the classroom, I'm going to say it like this. It is more contagious. It seems to spread a lot faster. So it's spreading a lot faster, which is why you're seeing it goes from 1 state to 38 states very, very quickly. And right now, preliminary results are it's not as deadly as the Delta variant, but you still should have some concerns because if you don't understand what your immune system is, it could still impact
underlying
factors and conditions in your body. So please don't go around, oh, it's not as deadly, it's not as strong.
No, don't buy into that.
Yeah,
at least not yet. And you know what? Even if it is, as you said, that doesn't mean that that's the case for you, because as you said, your immune system could be different. You could have other comorbidities or other, underlying disease or conditions that could make it as deadly or worse. So let's not go into that line of thinking. Absolutely.
We're going to bring on our next guest, which is Dr. Kendra Outler. Y'all know Dr. K. We call her Special K here, Black Doctor. Hey, Dr. Outler. So first question is just, could you give us the latest on where we are with regards to vaccinations here in this country, and talk a little bit about breakthrough cases? Because I know that's kind of been a big thing right now, especially with what's going on in sports. We see a lot of athletes are coming down, and we're having games being postponed and shifted around, and players not being able to play because they're having breakthrough cases. So kind of just give us an update of where we are with regards to vaccinations.
Okay, thank you so much, Dean and Dr. Renee and Dr. Crawford. I thank you. I will tell you, I'm your neighbor. I'm across the street at Walter Reed Military Hospital. And let me just say, too, that you would have made me a microbiologist. That was absolutely a perfect and engaging conversation and recap of microbiology that gave me hives. I'd be like, So I wish you were my professor, doctor.
Well, thank you very much.
So I want to start off with the most important number. I know that you said, Dean, the number vaccinated, but let me say that we are now at a landmark of over 800,000 people deceased due to COVID. And so this is no joke. And thank goodness for our scientists, our epidemiologists, and people like Dr. Kim Corbett, who helped create the vaccine that looks like us, and that we ended up with some type of treatment. So when you think about the 800,000 people who have died in the the African American Museum had a beautiful memorial and tribute out there. If you missed it, it was absolutely beautiful with the flags commemorating, I think at that time it wasn't over 800,000. But as we would say in medical school, look to your right and look to your left, and somebody's leaving. And we've had this experience over this last, 2 years. But now that we have the vaccine, the numbers coming out, the CDC report that over 202 million people have been vaccinated, according to the latest numbers. And I cross-checked that with the Mayo Clinic and what Hopkins is reporting as well. That puts us at about 61% of all Americans receiving both doses or a complete dose, which was one dose for Johnson & Johnson. So that is the definition of a fully vaccinated person. I also want to caution that when we think about these numbers, 202 million or 60%, we are relying on data that comes from the ground up to the federal level. Okay, so there is some lag in terms of the number counting. There's some inaccuracies that we have to allow for, but we are not nearly 80%. You know, like I tell my residents, look at the patient. Do they look to be 80 pounds, 70 pounds, or 70 kilograms or 80 kilograms? So we are not there. If we're between 60 and 70, we would ideally like to be in the 80 to 90 range. We are not there, so there's lots of work to be done. When it comes to African American populations, we're still kind of hovering less than around 10 to 12%. Is what I saw in some of the latest data from the CDC. And that puts us still on the bottom or the bottom third of the numbers to be vaccinated, which means as a community, we still have a lot of work to do. So even before we get into reinfections, I think that we have to do the baseline work of getting our vaccination numbers up because we're still dealing with primary infections. And that still seems to be, in particular for communities of color and African American communities, a problem. We need to, again, dispel the myths that are creating this problem. We still see that although white Americans, due to the total number, they are still not vaccinated in large numbers, but their rate of vaccine is 58%. So, you have to look at the absolute numbers, as we say in epidemiology. You have to look at the absolute numbers that you're getting these percentages from. But what I will tell you is that we still have a lot of work to do in our communities. I would encourage everyone to take the numbers from the CDC and then roll over to your state and see how your state is doing. For instance, Maryland is at 69.5 or 69.2%. So we're over 50% of all persons vaccinated, right? But then as you go across to the southern states, you start to see less than 50% of patients populated. And we know that from Georgia on over to Louisiana and over to the Delta, that we have our heavily dense Black populations. That is a problem. We also know that in these areas, we have poor infrastructure, healthcare infrastructure, and distance to major medical centers. Why is that an issue? It's an issue because when people can't get to major medical centers, they can't get the treatment. So if you get reinfected or primarily infected, and you end up with severe symptoms, you are away from where there may be one place to give you immunoglobulins to help with your treatment and save your life. So we actually do have a treatment protocols out there, but if you're away from them, you can't get to them. So I would encourage people to look where they are. PG County also has their data up, and PG County is lagging behind. I'm in Montgomery County. So when we look at these numbers, we have to ask ourselves, what do they mean for our lives? So I would encourage everyone to look at those numbers in respect to how that will help or identify a problem area in their community.
So do you think the vaccine mandates and travel restrictions are effective measures in reducing the spread of the virus?
I do. I think that we have to go back down history, what we call memory lane, and also go into our history books. We actually have always had some type of mandate. I mean, we have a public health system. The public health system has been in place since, the turn of the century. We've had syphilis outbreaks. We've had tuberculosis. We've had smallpox. And in 1991, if those things are too foreign to you, in 1991, Philadelphia had a very big outbreak of measles from a contained group of people who decided that they had a religious right not to vaccinate their children. But then what happened? Philadelphia, the state of Pennsylvania said, absolutely not. All of the kids of Pennsylvania are at risk because of you. So there's a balance of individual rights and public health wellness that we have to keep in balance. So after you voluntarily ask people to do something, then you voluntold, and then you have to do a mandate. And that's how we say it, and that's what has to happen. And that's where we are. And yes, we have seen that since the mandate has happened, folk want to keep their jobs, and people have lined up to be vaccinated. Let me just also, the people that are trying to keep jobs, and that does affect our working population as Black people in hospitals, nursing care homes, daycare centers. We rely on these. We rely on these so that we can get back into the business of going to work. Travel restrictions have helped. And like Mr. Dean said, as we've gotten back to some sense of normalcy, baseball games. I went to the Chicago Marathon. I was like, okay, I am going. It was a beautiful thing to be on a plane, going there, but you're always kind of tense about it. But yes, these travels, big events have added to the surge, but travel limitations did help. Vaccine mandates did help. And early in the pandemic, it did help for us to stop elective surgeries. And that was painful. Painful for the surgeons, painful for the patients, painful for me as an anesthesiologist as well.
Yeah.
Could I make a comment? I really appreciate what Dr. K has said and talking about the monoclonal antibodies as treatments. There are a lot of the anti-vaxxers, people who refuse to get vaccines, who are relying on monoclonal antibodies. They're like, I'm not going to get the vaccine. If I get sick, I'll just get the monoclonal antibodies. And as we've said a number of times, good luck with that. Because as she clearly pointed out, in your community, first of all, are you even near a hospital or near a center where you can get it? And second, if you get there, do they have them? There is a shortage of these different monoclonal antibodies, particularly the Regeneron product, which is the one that has activity against Delta variant. Third, you got to get it within a certain period of time for it to be effective. And in our communities, the same reason why she just pointed out that you may not live close enough to a hospital is a reason you may not be able to get in to get care in a reasonable amount of time. And one last thing you need to consider, because if you happen to have Omicron variant, then you are really, really rolling the dice, because the Regeneron product does have activity against Delta. It's a combination of two monoclonal antibodies. Neither of those antibodies have good activity against Omicron. At least that's what we think. Okay? Based on the structure of that virus and based on how it's likely to respond to that antibody, we don't think, well, it definitely does not have the same level of activity. May it still work? It may still work. Why even bother taking those chances? Why even bother taking those chances when there are other strategies that are more effective and more in line with the public health measures, as she has just mentioned?
So Dr. K, that brings up an interesting point. What role do you think healthcare disparities, because we know they existed before the pandemic, what role do you think healthcare disparities play in that, keeping the numbers of Black people low in terms of getting vaccinated, and then as well as we know that there's disproportionate in terms of our population, in terms of the amount of deaths that are happening as a result of people that are catching COVID. So what role do you think healthcare disparities play in that?
I mean, this has been huge, and I think there's been research out of University of Florida in the anthropology department that said this has been a disease that has basically outlined our health disparities that have existed in our healthcare system. I think one of the things in the Philadelphia area, Hahnemann closed in the middle of a pandemic. That sent 800 people home. I just read that article, when it happened at the start of the pandemic. And then that sent 800 people, primarily Black Americans, home that had been at this hospital for years. I mean, talking about I think it's something like over 50 years, right? We needed beds. We needed a facility. Those people went back to parts of Philadelphia that had poor infrastructure. We know Philly. If you know Philly, you know Harlem, you know Chicago, you know Atlanta, you know Jackson, Mississippi, and you know New Orleans. I mean, Charity Hospital has not been reopened since Hurricane Katrina. These are mega, what we call public health hospitals that have been closed and have stayed closed, decreasing the number of beds in lieu of what we call sleeker, sexier facilities, right? And then we get a pandemic. And so we have outlined this virus outlined itself in terms of taking down the most vulnerable, our elderly. It also outlined itself in terms of taking out the vulnerable in terms of our working poor, who oftentimes do have to rely on public transportation, Or then once we had to shut down public transportation, now you got to get a ride. You got to get a ride with more than one person. You start to have to work more collectively. So the disease, and then if one person got COVID, another person got COVID, then there you have it. I mean, what we found is that in a room, such as when we had even an event at the White House, one person with COVID, and then next thing you know, 12 people can come out in a room of 20 with the virus. And there's one person that's going to exhibit very severe symptoms. So what we find is that it's most severe in our infrastructure. We are now seeing a drop in the life expectancy of all Americans between 2019 and 2020 that we haven't seen since World War II, is what the reports are saying. And also, of course, like they say, when America gets a cold, Black folk get pneumonia. We are seeing a shortage of life expectancy in our population as well. So the reality is that disparities are growing. And I started my platform, anesthesiologist, because I wanted to make sure that that I kept looking at other diseases that strike us that are prevalent in the Black community: asthma, diabetes. We're coming to the table with these, and then on top of that, adding the pandemic. So when it comes to the vaccine, that seems to be more, it should be more urgent in our communities from a grassroots level to tell us, listen, we're already coming in a deficit with an overwhelming burden of health diseases, preventable diseases. And the only way that we can get out of this right now, our only arsenal is to be vaccinated. You know, I have arguments with people in my family. I lost a couple of people in 1 month due to a funeral, what we call a super spreader event. There you have it. People are hurt, people are bewildered, and now they say, I'm going to get vaccinated. So I've had that experience even in my own family.
Absolutely. We're going to bring in our next guest, and this is Dr. Oliver Brooks from Watts Health in California. Dr. Brooks, welcome to the program.
Thank you, Allison. It's been really rewarding to hear everything so far. You got a bunch of great experts going on.
Absolutely. You're just adding to that. You're just adding to that group.
Right.
So we've been hearing, that term breakthrough cases, right? And I think it's been amplified a lot more because those of us that watch sports and see what's happening, we see a lot of athletes now are having breakthrough cases because they're saying that the NFL is 95 or 97% fully vaccinated. NBA is the same number, but now we're getting games canceled. Players can't play because they're having breakthrough cases. How prevalent are the breakthrough cases, and should we be as concerned about those as we should be about the unvaccinated?
So breakthrough cases do occur, but there's really important data that we should know. If you're vaccinated, you're 10 times less likely to have a breakthrough case, 24 times less likely to be hospitalized, and generally speaking, no deaths. So it does occur, but the vaccine blunts the disease. So that people really need to keep that in mind. And I believe it was just stated, basically all we have is the vaccine and infection control procedures. I'll say this, I was just on a call literally today with the ACIP, and the data presented regarding Omicron was, of the 43 cases reported in the US, 72% were people that were vaccinated, fully vaccinated. So it's still happening, but two things. The data also shows that the vaccine is effective. Pfizer, it's the one we have data on, is effective, less so than Delta, but effective against the Omicron variant. And if you get sick, the infection, you're less likely to get sick and get hospitalized. So I think that that breakthrough concept and the thoughts of everyone saying, that's well and good, but it really doesn't change the bottom line, which is that ultimately you need to be vaccinated. So yeah, you're hearing it in the NFL, in the NBA, probably in the National Hockey League, although I don't keep up with that as much. I am from Philly, and I heard everyone talking about Philadelphia, so I understand clearly North Philadelphia and what happens when the hospitals get closed. But yeah, I mean, that's just where it is as it relates to it. You will get breakthrough cases. We're in the middle of a pandemic. We're not on the other side. We're in the middle. In fact, right now the case rates are going up. So we have to understand that there's a novel virus, and that we're going to see a lot of things that are going to be somewhat difficult to explain but the fundamentals just have not changed. Get vaccinated, wear your mask, wash your hands, keep your distance as well as you can.
It's a simple formula. And you know, I was as I was doing some research for this program, I found some numbers that said there have been approximately 829 breakthrough deaths from people that were fully vaccinated that died as a result of COVID complications. But as Dr. K talked about, over 800,000 people have died. So when we're talking about that number, I just did it on my calculator here.
That's 0.1% or so.
0.1%.
You know, that's great data, Ellis, if you have that. I didn't know that 839 number.
Right.
But that needs to be like bolded, underlined, and put in a different color, because that's what these anti-vaxxers need to hear. So what was it? One of the sisters just said, talking about in their own family. And we're all dealing with that in the families. So your chances of dying when you're vaccinated drop down to, you know,
0.1%.
You're more likely to be in an auto accident, which is going up, than you are to die from COVID.
Right.
Well, we have another you might say tool. It's actually the same tool, but it's the booster.
Yes, we do.
It's the booster. And you know, when we talk about these breakthrough cases, it's really interesting. I got a whole barrage of phone calls and messages from friends and family members, because there was this report from Cornell University about these 800 people who tested positive. So I did my undergraduate work at Cornell, and you know, it's the end of the year, so everyone wants their alumni to make those end of the year gifts. So they're trying to clean that up real quickly. The point is, those are individuals who were vaccinated. So they were vaccinated and they got the breakthrough infections. Some of them were Omicron. Some of them were Omicron. We don't know that all of them, because we don't sequence the way that we detect, you know, for the audience, the way that we detect whether you have Omicron or Delta. Everyone doesn't get that test. We do what is called a sequence, which means that genetic code that we've been talking about. You got to kind of do that for almost a whole section of the virus. Then you can tell which variant you have. So we don't do that for in most cases. We usually look at surveillance, which means the health department is tracking to see what the rates of those infections were. But these were people who were vaccinated. They got the infection anyway. So we know that, as Dr. Brooks mentioned, that the Pfizer has protection. It's less. It's less. The data we have from South Africa says it protects about 70%. Now, for most vaccines, 70% protection, we'd be doing cartwheels. That's really good protection from a vaccine. I'm sure my colleagues agree. It's just that we know with, you know, these COVID vaccines, you can get better protection. But that's 70% of the people who had the 2-shot vaccine. That's not the effect of having the boosting. And as I shared with the team before we came on, the Centers for Disease Control looked at data from nursing homes. This just came out. They've been tracking nursing homes. They've been seeing steady increases, just like everybody's been seeing, really going up, mostly unvaccinated individuals. When you looked at the people who have been vaccinated, it was a sharp reduction in the number of cases. And when you look at the people who had been boosted, so they had their first 2 shots and a booster, the line was flat. There was no increase in the cases over time. This is in nursing homes. This is a population of individuals which early in this pandemic, they had the highest rate. Over a third of the people who died early in the pandemic were people dying in nursing homes. And so now you see getting the boosting having a profound effect. And so not only do we have a challenge getting people vaccinated to begin with who are anti-vaxxers, but people who are vaccinated, getting them boosted can give additional protection against Delta and Omicron. Delta is still the predominant variant in the US.
It is.
So for right now, it is still a predominant one. That could change, but for right now, it's still Delta. But it really doesn't matter which of them. And if another variant comes up, the best protection that we have so far that we know are these vaccines. These are extraordinarily effective vaccines.
So, Ellis, let me say one quick thing, and
Sure.
to add to what Dr. Crawford said. First of all, the primary goal right now still is to get the unvaccinated vaccinated. That's more important than people getting boosted. Second, the data does show that the booster from Pfizer does improve protection against Omicron. But getting back to the initial point, especially in our community, although I don't know if people know it, and I believe it's still true, the highest rate of unvaccinated is among white evangelical Christians, rural. That's higher than Black folks. But for the purpose of what blackdoctor.org and what we are trying to stress, we need to get our people vaccinated, the unvaccinated vaccinated. And we can also walk and chew gum. So at the same time that we're getting our people that are unvaccinated vaccinated, we can also get our people boosted. But we really have to understand where the focus is.
So
go ahead, Dr. K.
No, we are seeing since the vaccine mandate, we are seeing better compliance with the booster. We are seeing better compliance with people going to get the second shot. I think they're saying a rate of over 55% of people going ahead and getting the booster, as opposed to this big delay. And I think that, so back to the original question about vaccine mandates and putting the pressure on people to make a decision to get vaccinated, I think that it is encouraging. And then once they realize, oh, okay, let me complete this series, and they realize they're getting back to some sense of normalcy, I think that is what encourages people to get vaccinated. And then once somebody's vaccinated, what we're finding, particularly in the African American communities, is your best advocate for being vaccinated is really the person next to you, husbands, wives, moms telling their children, because we want a sense of normalcy again. So we do know that is the best strategy, is pretty much each one tell one. And then also using our community strongholds like our churches and faith-based areas to encourage vaccination and tell stories about, hey, when I got COVID, this is how I felt. Wish I got vaccinated if you're fortunate. And then also just plainly encouraging. So we definitely need more churches and faith-based community centers and churches to tell their people to get vaccinated.
So I'm going to ask Dr. Brooks one more question, and we got to bring on our final guest. But Dr. Brooks, so it seems like the rate that we're going to be with COVID for a while. We just got to get used to COVID being around, and we might have to start looking at the booster or some sort of vaccine for COVID, like the flu, like people get a flu shot every year. Is that the road that we're heading down?
Well, again, Yogi Berra said the hardest thing to predict is the future. So it's hard to say regarding that. But it kind of looks that way right now. I can tell you Pfizer is experimenting. Well, they're doing studies on having a Omicron variant vaccine. Mrna is already doing testing on increasing the dose, bivalent Omicron Delta, monovalent Omicron only. So that would by definition mean you have to get another shot. So it looks like we are headed in that direction. The virus, I believe, is going to go from being a pandemic to being what we call endemic. It's always circulating at a slightly lower level. And as we wrap our arms around it with the vaccine, I think a lot of us kind of feel, I would guess that most of the panelists believe that at some point it's going to probably end up being like influenza, where you get different strains every year or the same, but checking for strains, setting up a virus tends to peak in the respiratory viruses tend to peak in the winter months, and probably going to end up having to get vaccinated on an annual basis. We do not know, because this virus is so tricky. No one predicted Omicron a month ago. So, I mean, we don't even know. But if I had to look into my crystal ball, though it's cloudy, I would say that I'm leaning toward us having to get more frequent and recurrent vaccination.
Oh, and real quick, I wanted to say, because I had somebody asked me this earlier, and they said, well, I know you're doing that program tonight because you asked this question. If someone, is it okay to mix your booster? So if somebody got a J&J.
That is a very, very good question. And the short answer is absolutely you can mix. They did the ACIP. We saw data that had like every combination. Okay, you got Moderna and then you boosted with Johnson & Johnson. You got Pfizer, you got boosted with Moderna. So they did there were 9 combinations, and all of them showed an increase in antibody levels and activity, vaccine effectiveness, no matter what you got boosted with, no matter what you got as your primary series. Just remember, after J&J, the time period is 2 months to get your booster versus 6 months for the mRNA vaccines.
Okay.
Yeah, some people have even suggested that you may even get a broader immune response. I mean, I think that remains to be determined, but it makes sense that could be the case. So we call this, the fancy term is heterologous boosting, for those who want to impress their friends at the next cocktail party or whatever. But that's what we call it. And so that could result in a better, more robust, more durable, long-lasting response. But we still don't know. There are a lot of things we don't know yet.
So I'm going to bring on our last guest, and this is Dr. Kimberly Matthew. She is a pediatrician, because we want to talk about vaccinating kids, right? So they've been approved. Some of the vaccines have been approved for children 5 to 11, and parents have some significant concerns, because we know there's a lot of misinformation, a lot of disinformation out there about the vaccines in general, just for adults. And now you're talking about vaccinating your child that is prepubescent. And so that brings on a whole nother list of concerns. Now, understanding this, that your prepubescent child has probably been vaccinated against many things already. But that notwithstanding, this is a relatively new vaccine. And so it has its own kind of set of issues separate from the vaccines that our children get. So welcome to the program, Dr. Matthews. And
thank you for having me.
First question I'm going to ask you is a very simple softball question. Is it safe to vaccinate your children aged 5 to 11?
Yes. Okay, that's the short answer. I just want to echo.
Why is it safe?
Exactly. Thank you for having me, Dr. Renee and Alice. This is a great discussion. I'm so excited. All of the panelists have been really informative about what's going on, and I'm happy to add to this discussion. So vaccines are safe, right? We've been discussing this all night. The panelists have all basically said the same thing. We've had more than 8 billion doses administered globally, billion with a B, right? And for the most part, everyone is doing well. We see that there are minimal side effects, and that's something that I, tell my parents all of the time. They ask, of course, about the safety, and I tell them that I'm a pediatrician, yes, but I'm also a parent. So, when they hear this information, they generally feel a little bit more comfortable with, whatever I'm going to say next. And when the time comes for my child to be vaccinated, I will definitely be bringing her to get her vaccinated. So, that's some of the things that we discuss in the office.
So rapid fire, do they have any impact on the child's ability to matriculate through puberty? Does it impact, if it's a girl, does it impact their menstrual cycle? If it's a boy, does it impact their puberty?
No. So the research has shown thus far that there's no impact on pubertal development, whether early onset or delayed onset of puberty, because I actually do get that question from a lot of parents. And a lot of parents are also concerned if the children will be affected with fertility issues in the future. And again, thus far, we have not seen that in the research, and I, tell them all of this. Yes.
Right.
Now, they're not giving the same dose, though, to the children as they give the adults. Is that correct?
No, they're not giving the same dose. So For children ages 5 to 11, they're receiving 10 micrograms of the Pfizer vaccine. Okay, those 12 and over are receiving 30 micrograms. Okay, so in a few months, Pfizer will likely authorize the vaccine to be given to those 4 years of age and younger, and they will be getting about 3 micrograms. So, when my little girl's ready, she'll be getting about 1/10 of the dose that I received.
I have a question, and I'd like for you to expound on it, because this is important in talking about our sickle cell population, which is 100% children of color. I spoke to one of the leading doctors at University of Texas, and she had her opinion and her encouraging of and questioning of the vaccine for her population by parents. What is your experience? I mean, she of course said, I need my population to be vaccinated. You have special needs children, Down syndrome children. How do those parents feel? But we have to remember that, our kids can be sick too. Chronic asthma in some children, or reactive airway diseases. And also we have an earlier onset of diabetes, particularly in minority children. And so what would having the vaccine, could be life-saving. Do you agree?
I definitely agree with you, Dr. K. I'm not a hematologist, so I will not speak to that. But overall, our children with chronic ailments, asthma, for instance, are doing very well with the vaccine. They have been protected throughout, our winter season with influenza and many of the RSV viruses. And those who have received the vaccine have, been saved from hospitalization. Of course, there are the very few cases, right, where we have the discussion of MISC, whereas that, the multi-system inflammatory condition, right? Again, those are very, very rare conditions and few and far between. So I think the point that we really have to drill into our parents and, our community, right? Because we're all people of color on the panel. That children that receive the vaccine, whether they do have chronic ailments, are protected. Okay, they're protected from COVID, and they will do well.
And also, I think that what people don't realize is those children go to school, and if they're not vaccinated, then they're bringing home all these different variants to the grown-ups, or in our community, it could be 3 generations or 4 generations living in the same house. So that's why it's so important, and it's so good that we now can vaccinate the kids, because the kids, just like any other, cold or something, kids bring home germs. So this is a germ you do not want coming in your house.
Right.
Ellis, let me make a quick comment. I'm also a pediatrician, trained pediatrician, by background. So a couple of things. First of all, in 5 to 11-year-olds, there have been 8,300 cases, 94 deaths. So children don't get it a lot, but they do get it and die. 5,200 cases of MISC. So that's not a good thing. The other thing, 2 other things. One is those people that were mentioned by Dr. K. Sicklers are felt to be immunocompromised. So they need to be vaccinated. The asthmatics, they're more, they got an underlying condition. And then last, I think most importantly, the only contraindications to the mRNA vaccines are a prior bad reaction or allergy to any component of the vaccine. So 99.9% of the population has no contraindication. So when there's concern, well, should my child get vaccinated? Is it safe to get vaccinated? The answer in 999 out of 1,000 cases, without even thinking, is yes, it is safe to get vaccinated.
Now, I just have to ask, Dr. Matthews, has anyone ever asked you what was in any of the other vaccines outside of COVID? I just find that so odd that we're really, people are like, well, what's in it? I'm like, do you know what was in the MMR? Did you even know what MMR stood for?
That's so true. Yeah, that's a great point. No, I have not ever.
But there's also the recent the vaccine with the human papillomavirus vaccine, right? When that came on, did we see as much pushback in terms of getting our girls
vaccinated? Right, exactly. That's an excellent point.
Good example.
But you know what? We did see some initial pushback, but it faded away. It was almost like a fizzle.
But you remember that
exactly.
We had a Republican governor, not to start any fights or go back down bad memories, but this is worth mentioning, and this is why Rick Perry made a mandate for that vaccine for girls in Texas, 13 years of age, to be vaccinated until he was caught. receiving funding from the pharmaceutical company, and then he had to walk that mandate back. So in recent years, we have had a vaccination that was mandated, that was new, but only when it came to female youth that we thought it was appropriate to go ahead and try to push that vaccine in that area. I'm just saying,
Yeah.
and if I remember,
This is the quadrivalent. This was the quadrivalent vaccine, correct?
Yes.
Okay.
Right.
Wow.
So
we had one question that I just wanted somebody to answer. Can you receive the booster if you are currently experiencing the cold or flu? Which I'm sure I know the answer, but I'll let one of the panelists cover it.
Yeah, so I would say the answer is yes. What I would do, though, is really tricky because I would want to test. I mean, what do we do this winter? I know all those practices have to make a determination if cold or flu symptoms can be COVID. But theoretically, so you're supposed to wait 10 days after the resolution of symptoms or 10 days after you test positive to get vaccinated, boosted or something. So if that person that you're referencing is 10 days past COVID or they test COVID negative, then the answer is yes.
And then we had another question: which booster would you recommend, Pfizer or Moderna? Whichever one you can get your hands on.
Right.
Absolutely. Or J&J.
Yeah.
J&J.
Well, no. This
But if
person
you
specifically
had-
asked that, so that's
Oh.
why I
yeah,
said
there
If you had the J&J vaccine initially, you should get a booster with one of the messenger RNA vaccines.
Absolutely. So I'm going to, as we're getting close to the end of this program, there is a word that seems to be driving a lot of the people that are kind of hesitant to getting vaccinated. And the word is certainty, right? And so what we've been giving a lot of great information tonight, but there's no certainty. And that's what it feels like some people are looking for with regards to getting vaccinated or not getting vaccinated. They want to be certain that if I get vaccinated, that it's not going to do anything to my body. I want to be certain that if I get vaccinated, that I'm not going to get COVID. And because we can't say 100% yes on those questions, we tend to have some pushback. And so how do we give people that are looking for certainty some semblance of certainty so they can feel more comfortable about going to get vaccinated? That might be a tough question, but
no. You know what I tell people? I say you will if you get COVID and you're not vaccinated, you will certainly probably have reaction. They don't even know all the things that could happen to you. There's somebody that's in the comments that said she had COVID. I think she said last year, and she's still trying to get weaned off of oxygen, and she's using a walker, and she's homebound.
right.
So
Well,
that's my thing. I just tell you that. I say, well, we do know that for a fact.
Yeah, when I go to the gym later this evening, I'm not certain that I will make it there. I don't have that level of certainty, and certainly going to the gym is a very low risk activity. I think the best response was given. Dr. Matthews just cited a whole bunch of data. Dr. Brooks, Dr. K, they've given us these are the real data. It's one thing to look at what the clinical trial says about the level of effectiveness. It's another thing when you're able to go on the CDC website, or as Dr. K was saying, look at your state, look at the vaccination rates, then look at the case numbers. They have case numbers of who was vaccinated versus who wasn't vaccinated. They have the data on deaths. They have the data on hospitalizations. You can look at the data. That's the best certainty that we have. We're dealing with an infectious agent that mutates. This is nothing new. All of these organs. Look, I do HIV research. And, we're talking about these variants. And in the world of HIV, you take a single patient that could have dozens, hundreds of what we call them quasi-species, because they're different viruses in the same person. And so this level of mutation that we see here doesn't even compare to what we see from other viruses or other organisms. And then, we've got drugs that are, potentially available for treating COVID. but we haven't talked anything about the potential for resistance to those drugs and how we're going to use those drugs. And we need to start thinking about that so we don't develop drug resistance mutations on top of mutants that can evade the immune systems and evade the effect of the vaccines. So nothing is certain.
Ellis, let me make one thing. Honestly, the people who are saying that to you, that's not what's in their heart. And I came to this understanding late. They're not looking for certainty. It's fear. Fear is the real word. They're afraid of getting vaccinated. So if we are in the position to try to get people vaccinated, which we are, skip the certainty part and try to get down to what it is that they're truly afraid of. And if you've seen one person that's resistant, you've seen one person, because everyone has a slightly different reason for not getting vaccinated. They know that nothing is certain. They know that. So they're using that as an excuse to not get vaccinated. So I think that for those out here listening to this, understand that when you're talking, if you believe in vaccinating and your friends don't, then really get down to it. Just look them in the eye and say, what is it that's really worrying you? Because otherwise we will not get them vaccinated.
You can turn on the news, the world news, and see they will have nurses on and doctors on talking about all the people in the ICU are unvaccinated. That should tell you right there. And they said also they're having trouble getting them off of the ventilators alive. That's it.
You know, they always say it only becomes relevant until it becomes you, you know, and that's part of the sad part of being human. I think that when you have honest conversations within the family, which we're going to be, some of us hopefully will have some family gatherings, that you pretty much need to do interventions. You pretty need to say, I love you to your next person next to you, niece, cousin, and check. And if, you know, and you don't want to spoil the mood, but I think that it will take Black families and Black communities kind of looking to the right and looking to the left and saying, you know, how can we improve and get out of this? And let's organize. Let's do what we do best, and that's work as a grassroots community and get people to the vaccine places. There are limitations. There's transportation issues. There's infrastructure issues that we really have to overcome. And I think that, you know, if you're able to impart that type of help in certain communities, it will increase our numbers. It will increase our numbers. Combine it. There's a food distribution somewhere near you. Combine the information. Get vaccinated. Get vaccinated. I'll volunteer, but let me just tell people when I hand out this food, get your vaccine.
Gotcha. Well, thank you all. This has been wonderful. We're going to continue the discussion. So this was focusing more on what's happening here. But on Monday, as Dr. Crawford mentioned, the research they're doing in South Africa, we're going to have some South African researchers here on Black Doctor Monday, 2 p.m. We're going to have some people from the UK, from Ghana, from all over there, and they're going to talk about what's happening all over the world. So we're going to take this global. We're going to take this COVID conversation global. So that's Monday at 2 p.m. I know that's a weird time.
2 p.m. Eastern. 2
p.m. Eastern in the U.S., but we understand that Africa is like 5 hours and 7 hours ahead of us. So we had to move our normal time up to accommodate for that. But don't let it miss it. And if you can't watch it live, make sure you watch it later on. And we'll replay it, we'll re-air it for you as well. So make sure we're going to do a worldwide discussion Monday about this, because this, as we talked about all night, this is a global pandemic. And yes, those are great numbers that Dr. K talked about in terms of the vaccination rates here. If you compare it to countries around the world, we're light years ahead. But we're not going to get out of this whole mutation, the whole variant thing, until we get more countries caught up to where we are with regards to getting vaccinated. So looking forward to that discussion. Thank you all. This has been,
thank you so much.
We got to go for 2 hours.
Wonderful meeting, everybody. Thank you all.
Right.
Wonderful holiday, everyone.
You too.
Take care.